Good morning. I am Dr. Velvizhy, working as a professor in Department of Pharmacology. So, in this video, we are going to discuss about coagulants and anticoagulants. So, what is meant by coagulation means this is the conversion of blood from liquid form to a solid form, or if the blood clots, it is called as coagulation. So, normally the blood inside the vessel remains in fluid state. This is due to a balance between procoagulants and anticoagulants, which we have normally in our body. Like examples of procoagulants, thromboxane, thrombin, and activated platelets. Anticoagulants, we have heparin sulfate, antithrombin 3, nitric oxide, and prostacyclin. So clotting factors, we have totally 13 factors named as 1, 2, 3 with absence of factor 6. So totally we have 12 factors named from 1 to 13. So coagulation pathway has two pathway. One is extrinsic pathway and another one is intrinsic pathway. So extrinsic pathway, when the tissue or injury occurs, then it need a factor from outside. It need a tissue factor, and this tissue factor go and activate the clotting factors. Whereas in case of intrinsic pathway does not require any activation factors. So if injury occurs, directly go and activate the clotting factors and coagulation occurs. So we'll move on to the coagulants. So coagulants is the agent or the drug which produces or which precipitate coagulation is called as coagulants. Okay. So we have some of the examples of coagulants. One is vitamin K and plasma fractions, cryoprecipitate, desmopressin, and we have antifibrinolytics and serine protease inhibitors. So among coagulants, vitamin K is the main thing. So how this vitamin K will produces coagulation is vitamin K is needed for the synthesis of clotting factor 2, 7, 9, and 10. So we'll move on to the preparations of vitamin K. We have K1, K2, and K3. K1 is mainly abundantly present in leafy vegetables, and K1 can be given orally or IV. It has rapid onset and prolonged effect. Whereas K2 is synthesized in the bacterial flora. This K1 and K2 require bile salts for its absorption. Whereas K3 is the synthetic form, it does not require bile salts for absorption. So, in case of obstructive jaundice or the patient requires coagulants, so in those cases, if you want to give orally, it is always go for vitamin K3, not K1. But vitamin K3 has slow onset of actions. So, how this vitamin K will produces? So, this is the mechanism of action of vitamin K. So, vitamin K is needed for the carboxylation of factor 2, 7, 9, 10. So this undergo carboxylation with the help of vitamin K in the reduced form. Okay, so vitamin K in reduced form is required for the activation of this clotting factor 2, 7, 9, 10. So this vitamin K from epoxide form to reduced form conversion occurs with the help of vitamin K reductase. So vitamin K reductase is the enzyme which is needed for the conversion of vitamin K from epoxide form to reduced form, and this reduced form is taken up by the taken up for the carboxylation of or activation of this clotting factors 2, 7, 9, 10. So coming to the uses of vitamin K, this vitamin K are mainly used for oral anticoagulant orders. So suppose if you are giving warfarin or something like that. So, if the overdose occurs, then vitamin K is the antidote. So, here always we prefer vitamin K1 intramuscular injection because of immediate action. And if the patient is taking long-term broad spectrum antibiotics, so what will happen is this broad spectrum antibiotic will destroy the intestinal flora of gut and also precipitate bleeding. So here any form can be given oral itself enough. In case of obstructive jaundice, we can give K1 parenterally, or else if you want to go for oral preparation, then always go for vitamin K3. And if there is a preterm baby or a hemorrhagic bleeding manifestations in case of newborn, will be going for vitamin K1. So these are the overall uses of vitamin K. So vitamin K are mainly used for prolonged use of anticoagulants and prolonged use of broad spectrum antibiotics, obstructive jaundice, and if the baby in case of preterm or newborn baby with bleeding manifestations. So coming to the adverse effects, so all drugs, even vitamins or whatever it is, it will be having an adverse effect. So the main adverse effects of vitamin K is dyspnea and hypersensitivity reaction. In some case, if the baby is having G6PD deficiency, it also precipitate hemolytic anemia. Then we'll move on to other coagulants. So apart from vitamin K, we have plasma factors fractions also, but these plasma factors and fractions are mainly preferred for hemophilia and 1 milligram diseases, because this for this condition only will be giving or will be administering a particular factors like factor 8 or factor 9. Whereas if the patient is having bleeding manifestation normally without any hemophilia or 1 milligram disease, vitamin K always holds the first line. So if the patient is diagnosed as vitamin hemophilia, it is hemophilia A or B. A is due to the deficiency of factor 8, and 9 is due to the deficiency, hemophilia B is due to the deficiency of factor 9. So in those cases, the particular factor which is deficient in those cases will be administered. In case of hemophilia A, will be giving factor 8, and in case of hemophilia B, will be giving factor 9. And another vasoconstrictor what we have is desmopressin. So desmopressin is a vasopressin analog. That is, it is called as antidiuretic hormone. Vasopressin is called as antidiuretic hormone. So what will happen is this vasopressin will be acting on two receptors. One is B1 and another one is B2. So this antidiuretic action is mainly mediated through B1, whereas vasoconstrictor action is mediated through B2 receptors. So this desmopressin is the vasopressin derivative, particularly act on B2 receptors. So what this desmopressin will do is, this desmopressin is found to increase the 1 milligram factor and factor 8 especially. So these are indicated in 1 milligram disease and hemophilia A, because this desmopressin stimulate these factors, no? So we'll be using in case of hemophilia A and 1 milligram disease. So what is the advantages of giving desmopressin is, the main thing is in case of suppose if you have a blood transfusion or plasma fractions, chances of transmission of hepatitis and HIV will be very high. Whereas in case of desmopressin, it's an injection, so automatically won't stimulate these factors 8 and 1 milligram disease. There is no risk of transmission of hepatitis or HIV. So this desmopressin can be given parenterally or intranasally. The other uses of desmopressin is diaphragm insipidus, doctor emesis, and post-lumbar puncture headache also we can use desmopressin. And we have local hemostatics. So what is local hemostatics? Means this will arrest the bleeding from the particular, like tooth extraction. After tooth extraction, if you have a bleeding from the tooth sockets or open wound, so for local arrest of bleeding, we'll be using this local hemostatics. So here we have thrombin. This thrombin is obtained from bovine plasma. And we have fibrin sealant. This is prepared from the human plasma. So this is mainly used to stop bleeding from the dental procedures. And gelatin foam also we have. Then vasoconstrictor like adrenaline also can be used to control bleeding in case of from the nasal cavity like epistaxis like that. Then astringent tannic acid and Russell Viper venom we are not at all using nowadays, but this also can be used as a local hemostatics. So this is about coagulants. So coagulants, we have different agents like vitamin K, desmopressin, and plasma fractions and local statistics. But among this, we have vitamin K is the main thing, and antifibrinolytic like tranexamic acid, ethoxylate, aminocaproic acid. These agents are preferred for control bleeding from the vessels or capillary bleeding nowadays more frequently than vitamin K. Vitamin K is mainly for massive bleeding or whereas antifibrinolytics are preferred from the minor bleedings. Like, okay, then we have an anticoagulants. So anticoagulants, natural anticoagulants we have, that is prostaglandin I2, which is also called as prostacyclin. So what this will do is it will inhibit platelet aggregation. And then we have antithrombin 3, and this is very very important natural anticoagulant we have, because this antithrombin 3 blocks factor 2, 9, 10, 11, and 12. Okay, this protein C also we have. This will act on factor 5 and 8, and we have heparin sulfate. So what is the action of heparin sulfate is, this heparin sulfate always enhances the action of antithrombin 3. So this heparin sulfate go and activate antithrombin 3, and this antithrombin 3 blocks factor 2, 9, 10, 11, and 12. We'll move on to the classification. So classification we have a parenteral anticoagulants and oral anticoagulants. So parenteral, the first and foremost one is always heparin, high molecular weight heparin. Then we have a low molecular weight heparin. Here we have the examples of enoxaparin, dalteparin, tinzaparin, reviparin, nadroparin, and ardiparin. Then we have synthetic heparin derivative, which is called as fondaparinux and idraparinux also. And thrombin inhibitors, we have hirudin, lepridin, bivalirudin, desidudin, argatroban, danacride, and rhodioxin alpha. So these things comes under parenteral anticoagulants. So heparin, low molecular weight heparin, synthetic heparin, and thrombin inhibitors. Then we have our oral coagulant. Here the example is coagulants and oral thrombin inhibitors like warfarin. So here always like warfarin is the main drug used as a oral anticoagulant, and still we have dicameral and acetocameral, all those things. Then direct thrombin inhibitors, we have dabigatran and rivaroxaban. So we'll move on to the history of heparin. So heparin was discovered by second-year medical students, and then Howell Hall named it heparin. Okay. This heparin is also present along with mostly present with mast cells in lungs, liver, and intestinal mucosa. So heparin is high molecular weight, as I told earlier. So it is also called as high molecular weight heparin. So what will happen is it will crosses the membrane very poorly. So always we go for parenteral preparation. So high molecular weight heparin is given parenterally. Okay, so low doses subcutaneous or high doses we can use subcutaneous or even IV injections also. These are metabolized in liver. So moving on to the mechanism of action of heparin. Heparin, as I told earlier itself, heparin enhances the action of antithrombin 3. So what is the act to recollect? Just if you recollect and see, antithrombin action is it will inhibit factor 2, 9, 10, 11 and 12. This is the action of heparin. Whereas what is the difference between heparin and low molecular weight heparin is low molecular weight heparin predominantly inhibits 10 factor, 10 factors. Okay, whereas heparin inhibits 2 and 10 as the main, and even apart from 9, 11, 12 also, whereas low molecular weight heparin predominantly inhibit factor 10. So once the coagulation pathway is activated, what will happen is these factors like 2, 9, 10, 11, 12 need to be neutralized by antithrombin. So what will happen is, just moving on to this slide. So just see here. So here it is the action of heparin and this is the action of low molecular heparin. So as I told, this is a high molecular, this is unfractional heparin. So have high molecular weight. Okay. So what will happen is this will have place to bind antithrombin. So initially antithrombin will bind and then again this factor 10A and 2A also bind here. Whereas in the case of low molecular weight heparin, antithrombin will bind and then only 10A factor will get bind with the antithrombin 3. Whereas here 2A factor will not bind. So that is the main difference between heparin and low molecular heparin. So heparin, it have chances, it gives chance for factor 2A and 10A to bind with antithrombin, whereas low molecular weight heparin give place only for factor 10A and not for other factors. So when we are starting anticoagulant, especially heparin, we always monitor two therapy. One is called as APTT, that is called as activated partial trophoblastic time. So the normal time is 20 to 35. If it prolongs or if it goes on increasing, then the patient have chances to develop bleeding manifestations. But if the patient is taking anticoagulant like heparin or some other, then it may increase till up to 80. So if it goes beyond that, we have to titrate the values. Then PTINR, that is international prothrombin international normalized ratio. The normal is 1 to 1.5. Maybe if the patient is taking anticoagulant, it may go to 2.5 like that. But if it goes beyond that, the patient will be having easily the bleeding manifestations. So these are the difference between high molecular weight heparin and low molecular weight heparin. So if you see the molecular weight, it is high for heparin and it is always low for low molecular weight heparin. So biotransformation metabolism occurs high with low molecular weight heparin, whereas in case of heparin, it is low. Half-life in case of heparin, it is shorter. So we have to give the increase the frequency of dose. That means twice a day. Whereas low molecular weight heparin, it is longer. So we'll be giving always once a day dose. Mechanism, as I told, heparin will inactivate both factor 2A and 10A, whereas low molecular weight heparin inactivate only factor 10A. So anticoagulant effect is more will be in case of heparin because it inhibits lot of factors 2A, 10A, and even other factors also. Whereas in case of low molecular weight heparin, anticoagulation effect is little less only. Okay. And monitoring is always required in case of heparin. If you are giving heparin, we always go for BT INR monitor. Whereas in case of low molecular weight heparin, no need to monitor this INR value. Adverse effects, because of it inhibits lot of factors, heparin is always have high chances of adverse drug reactions compared to low molecular weight heparin. And excretion, these heparins are mainly excreted via reticular endothelial system, whereas low molecular weight heparin are excreted through kidney. So in case of heparin, suppose if the patient is having renal failure or dialysis patient, heparin is the drug of choice, not low molecular weight heparin. And we have a specific antidote for heparin, that is protamine sulfate. This protamine sulfate also reverses low molecular weight heparin, but not to the full extent. Okay, and rate cost wise, heparin is always the cheaper than low molecular weight heparin. And use almost same for heparin and low molecular weight heparin, but these low molecular weight heparin are mainly preferred for orthopedic procedure like hip fracture and a few long bone fractures, pulmonary embolism, and unstable angina. So we're moving on to the uses of heparin. So heparin are mainly used for venous thrombosis than arterial thrombosis, giving more response to heparin. So this can be used for both prophylaxis as well as prevention of deep vein thrombosis. So deep vein thrombosis are developed in the patient who have prolonged bedridden, are not moving, chronic older patients or something like post section cesarean sections and those things, and old people, post-operative stroke patient like fractures, elective surgeries. So these are the patients who have high risk of developing deep vein thrombosis. So prophylaxis dose is 5,000 international units subcutaneously 12 hourly supposed to give, whereas in case of treatment dose 5,000 to 10,000 international units IV, first bolus followed by 1,000 units per hour infusion 6 to 7 days, followed by, then you can substitute with warfarin. But usually warfarin will be started with the 3 days oral. Okay. Okay. Then other uses apart from deep vein thrombosis, we can give in case of ischemic heart disease like unstable angina after post MI, angioplasty surgery or CABG surgery. For those cases also we can. Then rheumatoid heart disease or atrial fibrillation have high chances to develop a stroke or myocardial infarction. No? So those cases also we will be giving anticoagulants, and it will decreases the stroke incident due to embolism. Then cerebral vascular diseases. Then these are the some other uses of anticoagulants like disseminated intravascular coagulation, especially with abruption, associated abruption placenta, malignancy, infections, those things, and treatment of peripheral embolism, cardiac bypass surgery, and hemodialysis and pregnancy. Okay, adverse effects, as I told, these are the anticoagulants, right? So always bleeding manifestation is the first adverse effects to develop with, then thrombocytopenia. If used on a chronic or long-term basis, it produces osteoporosis and fracture. Even it causes hair loss, alopecia, allergy, and anaphylaxis. And one important adverse effects of this is heparin-induced thrombocytopenia. This is the most common adverse effects with heparin. So this adverse effects is low with low molecular weight heparin, and this heparin-induced thrombocytopenia sometimes life-threatening also, and this is due to the development of antibodies against IgG. Production of IgG antibodies against platelets. Okay, so what we have to do is in this cases we should not give platelet transfer because there is development of antibodies against platelets. So even if you transfer platelet, it will destroy all those things, and this bleeding manifestation will be continued without stopping it. So here what you're supposed to do is immediately stop heparin, and we can give substitute with direct thrombin inhibitors. And always in case of pregnancy, heparin is the drug of choice because I told it because of high molecular weight, it does not crosses the barrier, placental barrier. So here pregnancy, heparin is always the drug of choice if required. Then contraindication to anticoagulant or contraindication to heparin all remain same because even oral everything the contraindication is same. Those conditions or those patients who have chances to develop bleeding manifestations are contraindications to heparins like hypersensitivity reaction, bleeding disorders like hemophilia, thrombocytopenia, severe hypertension. If the patient is having a subacute bacterial endocarditis, tuberculosis, because of persistent cough, no, they will be having chance hemoptysis, all those things. Then aspirin, if the patient is taking aspirin, then you have to stop the aspirin. GAD ulceration, threatened abortion, and advanced renal and hepatic failure. And then we'll move on to low molecular weight heparin. As I told, it has molecular weight is less and it inhibit factor 10A. Okay, what is the advantage of this low molecular weight heparin is the chances of thrombocytopenia and hemorrhage is less with this group of the drug. So apart from this, it also have some other advantages like it have better subcutaneous bioavailability. So bioavailability will be more with low molecular weight heparin and longer half-life, so we can give once daily dose. And since, as I told, we have to monitor PTINR in case of heparin. If you want to give no molecular weight heparin, you don't need to monitor this PTINR. So it is the here the drug is given in milligram basis, can be calculated based on the body weight, whereas whereas heparin will be given in units. Okay, and here, as I told, adverse effects also very less compared with heparin. Then we'll move on to synthetic heparin. So synthetic heparin, we have fondaparinux. So it will inhibit factor 10A. Okay. So this is also given subcutaneously once daily 2.5 milligram, and bioavailability here is 100%. So heparin is having low bioavailability. Compared to that, low molecular weight heparin will be having little high, whereas synthetic heparin is having 100% bioavailability. Half-life is 30 to 21 hours, so always going for OD doses. And the here instance of thrombocytopenia, heparin thrombocytopenia, all those things will be very, very rare with fondaparinux. So these are preferred for any knee surgeries or pulmonary embolism nowadays. And reason we have idraparinux also approved from this group. Initially I told about antidote available for the heparin toxicity, like just called as protamine sulfate. This protamine sulfate is not required to usually, because if you stop heparin, then definitely the problem will be overcome. But when this protamine sulfate is required is if the patient is going for any cardiac or vascular surgery, you have to terminate the heparin action immediately. Then those cases we can go for protamine sulfate 1 milligram. So 1 milligram of IV, 1 milligram of protein sulfate utilizes 100 units of heparin. So based on the units, whatever you have given, you just calculate and give the protein sulfate. So in case of low molecular weight heparin, it will reverses partially, whereas synthetic heparins like fondaparinux, it will not reverses the actions. Yeah. Then we have a direct thrombin inhibitors. So what this direct thrombin inhibitors will do is bind with thrombin directly without any requirement of antithrombin 3, whereas heparin and low molecular weight heparin binds with antithrombin 3 and then only just go and inhibit the clotting factors, whereas here this is direct thrombin inhibitors. So directly go and inhibit the thrombin. It does not require antithrombin 3 for its action. So here the main drug is ferritin. It was preferred from the salivary gland of leech. Then we have bevacizumab, desiludin, argotropin, nadapride, and prodecogen alpha. So leprodin, it is a recombinant form of heparin. So this is the drug of choice for heparin-induced thrombocytopenia. So we have to monitor APTT if you giving thrombin inhibitors also doesn't have antidote for this. Okay, and this leprodin is preferred for hepatic insufficiency. Adverse effect, it also have hemorrhagic manifestation, hemorrhagia, all those things. Then so other parental thrombin inhibitors are same like leprodin. Okay, then oral thrombin inhibitors we have dabigatran, that is direct thrombin inhibitors, and rivaroxaban apixaban, it inhibits factor 10A. So here coagulation monitoring is not regular, like in case of thirdin we have to monitor APTT, right? So here orally we have no need to monitor. Okay, so it is almost found equivalent to low molecular weight heparin. So this is also used for the prevention of deep vein thrombosis in knee or replacement surgery and stroke in AF. Then antidote to direct thrombin inhibitors, we have recent drugs like idarucizumab, andexanet alpha, and siraparentan. Then we'll move on to warfarin, which is the main drug as a oral anticoagulant. So always a cheap and self-administration with this group of drug. So it also have 100% bioavailability, and the plasma protein is also highly plasma protein. So this drug is the long acting, 99% of the drug bonds with plasma, and it crosses the placental barrier and it causes teratogenic effect. So it is always avoided in case of pregnancy. Okay. Yeah. Coming to the calcium action of warfarin, if you remember the action of vitamin K, as I told, vitamin K is required for the synthesis of factor 2, 9, 10, and 2, 7, 9, 10. Okay, so these factors are synthesized with the help of vitamin K. Okay, yeah. So warfarin is the one which will blocks this synthesis by inhibiting vitamin K reductase enzyme. As I told, vitamin K reductase enzyme is the one which converts vitamin K from epoxide form to reduced form. Reduced form are required for the activation or carboxylation of 2, 7, 9, 10 factors. Okay, so this warfarin will inhibit this enzyme, vitamin K reductase. So what will happen? Vitamin K will not convert it into reduced form. If it is not available in reduced form, then it will not available for the carboxylation or activation of these factors. So it blocks this clotting factors 2, 7, 9, 10. The same path. So coming to the uses of warfarin, it's same like heparin. We can use in case of deep vein thrombosis, surgery, bypass surgery, stroke prevention, myocardial infarction, post MI, all those uses you can write. And here monitoring is required because of this drug is having low therapeutic index. So it have very narrow therapeutic range. So we always monitor here, but here in this case, we always monitor PT-INA. Okay, prothrombin time we take. So coming to the adverse effects, it also produces bleeding manifestation like epistaxis, hematuria, bleeding, internal hemorrhages, and it produces cutaneous necrosis due to inhibition of factor C. Okay, yeah. Yeah, in case of warfarin toxins, so heparin we have an antidote like protamine sulfate. For in case of warfarin, we have vitamin K as an antidote. So vitamin K uses, we had studied about prolonged use of oral anticoagulant. So this is the one. So warfarin toxicity always treated with vitamin K. Coming to the contraindications, yeah, same like hypersensitivity reaction, hypertension, aspirin, if the patient is taking aspirin, tuberculosis, everything can be written for here also. And apart from that, pregnancy is also contraindication for warfarin. Yeah, these are the difference between heparin and warfarin. So heparin always parenteral, warfarin it is oral. And heparin is highly polar charge molecule, whereas warfarin is uncharged. So heparin onset of action is rapid, but warfarin takes some 16 hours to produce its action. So mechanism, heparin accelerates the inactivation of clotting factors by activating antithrombin 3, whereas warfarin inhibits the vitamin K reductase and inhibit the factor 2, 7, 9, 10. Therapeutic index, heparin is safe, whereas warfarin is no low or narrow therapeutic range, it's not safe. Monitoring, here we always monitor APTT, that is activated partial thrombocytopenia, whereas here we always go the PTIN. Adverse effects, thrombocytopenia, osteoporosis, alopecia, anaphylaxis. Here necrosis of the breast is the most common adverse effect associated with warfarin. So if you want to start anticoagulant for the patient, always start with the warfarin first. Then switch over to always start the heparin first and switch over to warfarin in third or fifth day. Within third to fifth day, we have to switch over to warfarin. So antidote for heparin toxicity is protamine sulfate, whereas antidote for warfarin is vitamin K. So contraindication, pregnancy is the contraindications for warfarin, and heparin it is not a contraindication. So drug interaction is also not significant with heparin, whereas warfarin, that is oral anticoagulant, we have a lot of drug interaction. So when you start with warfarin, you have to be very careful on patient what are the drugs they are taking. So to summarize, bleeding manifestations are mainly controlled with the help of vitamin K and antifibrinolytic like aminocaproic acid and tranexamic acid. But when moving on to a coagulant, we have a parenteral coagulant and oral coagulant. So parenteral, we have heparin, low molecular weight heparin, direct thrombin inhibitors, and synthetic heparin, all those things. Whereas oral, we have warfarin and direct thrombin, oral direct thrombin inhibitors. So heparin, the main action is it will enhances the action of antithrombin 3. So by enhancing the antithrombin 3, you just go and inhibit factors 2, 9, 10, 11 and 12. Whereas low molecular weight heparin will inhibit only the factor 10A. So that is the main difference. And low molecular weight heparin are the most preferred drug nowadays because of lot of advantages like high bioavailability, once daily dose, and milligram given in milligram, and no need to monitor like APTT, and adverse effect chances of adverse effects also very less with low molecular weight heparin. But there are some contraindications to low molecular weight heparin also, like pregnancy, we always go for heparin, and renal failure we always go for heparin, those things. Then synthetic heparin is the one fondaparinux which has been used and have highly by 100% bioavailability, and more replaced by nowadays most of the drug anticoagulants are replaced by synthetic heparin steroids. But nowadays mostly fondaparinux or low molecular heparins are preferred. Then we have direct thrombin inhibitors like leprodin, bivalirudin, all those things. So these are mainly preferred for heparin-induced thrombocytopenia and some other conditions also. And then we have an oral drug like warfarin. So warfarin is the oral anticoagulant. It inhibits vitamin K reductase enzyme, and won't act on the factors 2, 7, 9, 10. And compared to heparin and warfarin, heparin is a parenteral, warfarin is the oral. We always start with heparin and then we switch over to the warfarin therapy. Antidote for heparin is protomin sulfate, and antidote for warfarin is vitamin K always. And these are the some questions. If it is a bleeding disorder, if the patient comes to you with a bleeding disorders, we always go for vitamin K as the main drug of choice, and antifibrillary. And in case of severe sepsis, we always go for droticogen alpha. There is also a direct thrombin inhibitor. It improves the mortality in case of severe sepsis associated with organ dysfunctions. Thank you.